Okay, we're here, and I need you to respond in the chat box if you can hear me talking, please. Just tell me in the chat box if you can hear me talking. Okay, Dr. Donaldson, yes. Okay. Most everybody can hear me talking. That's good. Okay, now I do want to state that I did add some to the caffeine talk that we had a couple of weeks ago. So if you want that additional transcript, just send me an email for it, and I will send you that additional transcript, because there were a couple of things that I failed to mention, but I added them to the transcript, which you can see and have to present to your patients also. Okay, I will just put it on here if you want to ask for it. drBBRK@hotmail.com. It's right there. And if you want to call me about anything, 469-995-9907. So there's my contacts. Okay. So let's see here. Okay, we're going right into it. Maybe make that a little bit smaller, perhaps. Okay, here we go. Okay, again, if you want to get the transcripts of the caffeine from 2 weeks ago, I've added to that. Don't want you to miss out. Just contact me at drBBRK@hotmail.com, or you can call me 469-995-9907. Okay, manipulation of hormones and other chemicals by ingestion. So we're going to talk about how to change levels of chemicals in the body just by food. And I'm going to prepare something special about vitamins and minerals in that respect. We're going to talk about very specific blood levels also, and that's going to be on another issue of Thursday night class, so make sure not to miss any of those. Manipulation of hormones and other chemicals by ingestion. Remember that any recommendations apply to certain susceptible individuals, not to all individuals. So some of the stuff you get into when you're making a presentation like this is, oh my gosh, I can't eat anything. Well, that's not it. This only applies to certain individuals, and you have to observe whether this is going to affect that given individual or not. Grapefruit is recommended not to be taken with drugs because it prevents clearance by the kidneys. When this occurs and the drug continues to be taken, it may reach 4 to 5 times or more the blood level with accompanying adverse reactions from overdose levels. We're going to talk about a lot more than grapefruit, by the way. Chemical in grapefruit responsible for this is psoralen, which in turn is found in foods containing furocoumarins. Foods rich in psoralen. Now, psoralen itself is used. Okay, somebody has your. That's Dr. Whitaker. You got to watch here, and don't have your microphone on. Everybody can hear you, and you talk over me here. Okay, psoralen is a compound that's been used in treatment of psoriasis, vitiligo, and eczema. Okay, you got to mute yourself there. I muted you for you. Sorolins are naturally occurring substances belong to a group of compounds known as furocoumarins. Figs are on the top of list of foods that contain sorolin, along with other vegetables such as celery, celeriac, carrots, parsnips, root parsley, that are good natural sources of sorolin. Okay? So basically you can use any of those foods. Now, please don't unmute me because we can hear you talking, okay? So please don't unmute, all right? So figs, celery, celeriac, carrots, parsnips, root parsley, and certain spices and herbs rich in sorolin, anise, cumin, caraway, chervil, coriander, fennel, dill, and mustard. Please do not unmute. Please do not unmute. And mustard make the list of foods rich in sorolin. So, if you have somebody who has psoriasis, vitiligo, eczema, then any of these foods or spices can help with that. Okay? And so you would be telling people to eat more of those in that case. And again, figs, celery, celeriac, carrots, parsnips, root parsley, anise, cumin, caraway, chervil, coriander, fennel, dill, and mustard. So those are very, very common. Also, when activated by sunlight or another source of ultraviolet light, sorolins may have phototoxic, mutagenic, and photocarcinogenic effects. Consequently, foods rich in sorolin may cause dermatitis, sunburn, and age spots or liver spots when skin is exposed to sunlight. So there are some unwanted side effects that go along with sorolins also, and you got to watch that. So if you are prone to sunburn, dermatitis, age spots, you want to stay away from those foods majorly. High intake of sorolin combined with exposure to ultraviolet light has also been associated with an increased risk of skin cancer. So the FDA has approved sorolin plus ultraviolet A as a treatment for severe cutaneous psoriasis. So even the FDA has noticed some good things about it. You got to look at the bad things that can happen also. If trying to avoid eating foods that contain sorolin due to their ability to react with sunlight, keep in mind that also touching these foods may cause unwanted reaction in sensitive individuals, causing these substances to collect on skin, and when exposed to ultraviolet rays may cause severe sunburn, age spots, and other damage to skin. So therefore, use gloves when handling sorolin-containing foods to reduce the risk of adverse reactions. Now, grapefruit. More than 85 drugs are known or predicted to interact with grapefruit, enhancing systemic drug concentration through impaired drug metabolism. These can cause adverse effects, such as torsade de pointe, rhabdomyolysis, myelotoxicity, respiratory depression, gastrointestinal bleeding, nephrotoxy. So, gastrointestinal bleeding, for example, you're taking drugs with grapefruit, bleed from the intestines, can cause the kidneys to fail, can cause the respiration to go down. Okay, we're going to talk about these other three here in just a little bit. Grapefruit is the most widely examined, but other citrus have similar consequences. Having similar consequences act by an additional mechanism to cause diminished systemic concentration of certain drugs by inhibiting drug transporters. The most well-known and well-studied interaction is that of interference in the activity of cytochrome P450 3A4 or CYP3A4 enzyme. What are the key scientific concepts of grapefruit drug interactions? Okay, and we have a question here. Is there a food that can counter the effects of sorolin effects and or sunlight? Not that I'm aware of, no. Okay, yeah, and people have told me about the crackling at times there, Dr. Weeks. I'm not really sure what to do about that. We've tried a couple of different microphones, doesn't seem to help. Sorry about that. Okay, drug metabolism. What are key scientific concepts? Drug metabolism involving oxidation by enzymes belonging to the P450 superfamily are involved in the bioinactivation of about 50% of all drugs. Wow, look at that. So it inactivates 50% of all drugs too. So it has some effect by inactivating enzymes. It inactivates 50% of drugs, and it hypes up a significant amount of drugs. At the very least 85%, or 85 of them, and they know there must be a whole lot more, but how many thousands of drugs are there? CYP3A4 is located in epithelial cells, or enterocytes, lining the small intestines and colon, in parenchymal cells of the liver, or hepatocytes. Orally administered drugs can be metabolized twice prior to reaching systemic circulation, and the percentage of drug absorbed unchanged, or oral bioavailability, can be markedly attenuated, such as felodipine, which is normally being reduced 15% of the oral dose, which is low innate bioavailability. We'll talk more about that drug later. For this reason, it is subject to potentially dramatic increase in systemic exposure and associated higher risk of overdose with grapefruit as a result of diminished CYP3A4 activity, primarily in the small intestine rather than the liver. So basically, you're blocking the thing that blocks the absorption, and now you get a higher amount of absorption and you get a lot more. Now we have a problem with it clearing the kidneys, which is suppressed also. Okay, the chemicals involved in this interaction are furanocoumarins, which are still furocoumarins, okay, which are metabolized by CYP3A4 to reactive intermediates that bond covalently to the active site of the enzyme, causing irreversible inactivation. This activity in the small intestine is impaired until de novo synthesis returns the enzyme to its previous level. So it really causes a lot of issues, sufficient to cause clinically relevant increased systemic drug concentration, subsequent adverse effects. Now, Seville oranges used in marmalades, limes, and pomelos, which is, a lot in Latino markets, are really high in these. But sweet oranges don't produce this interaction. So you got to look for those particular fruits along with grapefruit. Unless healthcare professionals are aware of the possibility that the adverse event they're seeing may have an origin in the recent addition of grapefruit to the patient's diet and any of these other foods too, it is very unlikely they'll investigate it, and the patient may not volunteer this information. So I guarantee you, most docs, even if they're aware of grapefruit, they're totally unaware of the rest of these foods that we just talked about. And probably most of you weren't either. And, this is, all these other foods right here. So you're already at a big disadvantage because you may only know a grapefruit and you don't know about the rest of them. Well, you have a list of them now, okay? Current data are not available to provide an absolute or even approximate number representing the true incidence of grapefruit drug interactions, and of course that means all these other foods in routine practice. People older than 45 are the prime purchasers of grapefruit in particular and receive the most prescriptions for drugs. So basically, you got the disadvantage of they buy more grapefruit and they purchase more drugs. So they are at higher risk, okay? In addition, pronounced interaction has been shown to occur in patients older than 70, can have decreased capacity to compensate for excessive systemic drug concentration. So here is an even more susceptible population, those older than 70. Here's that drug again. Phenyldiapine normally lowers blood pressure, does not cause the compensating increase in heart rate in older adults. When ingested with grapefruit, as in young and middle-aged people, likely because of attenuated baroreceptor sensitivity associated with age, thus appear to be especially vulnerable. So this is what puts them even in a higher category. Serious effects includes torsade de pointes, rhabdomyolysis, nephrotoxy, breast cancer. Torsade de pointes. Risk of sudden death can occur with excessive prolongation of the corrected QT interval. So we have problems with the heartbeat. As the antiarrhythmic agent of amiodarone. And dronedarone, the chemical analog of this, was associated with reports of ventricular arrhythmia, cardiac arrest, and torsade de pointes from a systemic drug concentration that was 300% of that of a control with grapefruit juice. So 300% higher than those that weren't taking grapefruit. That's quite significant. Torsade de pointes can also occur with certain anti-cancer agents, such as the tyrosine kinase inhibitor, nilotinib, with a single glass of grapefruit. Okay, so they're only talking about grapefruit, and they're not even mentioning all these other foods. And, I want you to just kind of think of that. We're going to come back here, but think about those people. They have limes, they have pomelos. So in the Latino market, this is going to be quite high. Wealthy people have marmalades, in a lot of their foods. And let's think about, just us ordinary people eat a lot of dill pickles. A lot of people have fennel herb for lung issues. Chervil, coriander, caraway, cumin. Oh, this is really big. Mustard, okay. Anise. This is what's used as the flavoring in licorice candy. There is no licorice in licorice candy, so anise puts somebody at really big risk. Celery, celeriac, carrots, parsnips, root parsley. Hey, celery and carrots, salads. So we're being put at, all of us, in great jeopardy here, simply because doctors don't know about these other things that can contribute to that. Okay, rhabdomyolysis. This is reported after 10 days concomitant consumption of fresh grapefruit at usual amounts. This is the consequence of profound damage to skeletal muscle tissue. Now, you can also have this just from somebody that exercised a lot. I have for decades. Every time I go in, I have this high because I exercise heavily. And that's just a normal course of heavy exercise too. So you don't want to be, you got normal breakdown, a lot of breakdown when you exercise heavily. So this isn't necessarily a bad thing if you exercise a lot. Now, the release of large quantities of proteins such as myoglobin in the blood and acute renal failure. So acute renal failure has high amounts of this in it. Active forms of all statins can produce this toxicity at excessive systemic concentrations. So guess what? They want to put statins in our drinking water, right? Which is going to make all of us more susceptible to acute renal failure from stuff like this. Wow. Anybody think of that? Let's see that in the comment box over here. What do you think about that? They want to put it in our drinking water so that we all have statins, supposedly to be healthier, but that's going to put us all in jeopardy of acute renal failure when we're drinking tap water. Let's see some comments about that over here in the chat box. What do you have to say about that? Statins should never been on the market. Probably not. Anybody else? Anybody else with a comment here? Okay, simvastatin with grapefruit juice at high volume was elevated 700% and 330% at a more usual amount of juice. Wow. 5 by 55 is the industry chorus. They can have my share. That's good. Big Pharma's decision, of course. Atorvastatin was 180 to 250% increase. Wow, don't you think your patients need to know this stuff? Don't you think they need to know this stuff? Unethical and corrupt drug companies and politicians, absolutely. How many of you realized what we're talking about with the rhabdomyolysis, acute renal failure, and that all statins cause it, and that any of those foods that we mentioned here can cause a problem, which is all of us are eating them, right? How many of you knew that? Let's see a yes or a no in the chat box here. One did. Dr. Dixon, Dr. Garbett, no. Thompson, no. Donaldson, no. Peyton, no. Some of it, no, yes, no. So most of us know a couple of yeses, a couple of them, some of it, but don't you think you ought to be telling your patients this so that they're aware of it, okay? Nephrotoxicity can occur with calcineurin inhibitors, cyclosporine, tacrolimus, vital in preventing organ rejection after transplantation, both having a narrow range of therapeutic blood concentrations below which lacking sufficient efficacy, above which is causing toxicity. So you have a very little range right in here. But cyclosporin with grapefruit, the juice raises it 162% to 670%, and 600% with grapefruit. Okay, so the juice raised it this much, the grapefruit this much. And this is in people who are having organ transplants. Wow, that is really scary. So any of those foods that we just mentioned can set this off and cause a problem with organ rejection. Tacrolimus with grapefruit juice raised 1,000%. The juice, 1,000%, 500% with a large amount of grapefruit marmalade and acute renal dysfunction accompanied. Wow, look at that. So there are some drugs causing a lot of kidney issues with not a whole lot taken and causing a big amount of problems. Breast cancer, 30% higher risk with taking oral estrogens, 1/4 grapefruit or more per day in one study. Now, another study found no association. There really haven't been that many studies on this, and so, you know, we'll be looking for a meta-analysis later on for that particular issue. Now, when somebody comes into me with any abnormally high values in blood or urine, I immediately question the intake of any of those foods that we're talking about. I've found that a lot of those can be raised, it can raise any blood value whatsoever. And so I just tell people, hey, if you're eating a lot of those, get off of them. And amazingly, it drops really quickly in almost every case. So one of the things I've told you before that come in on this Thursday class, and those of you who've taken my part 4, is that I take people off of far more things that I put them on because I see these reactions occurring, okay? I'm not quick to give people things. I'm quick to find out what's actually causing the issue. I'm not against giving them something to help them through it quicker, but you got to figure out what's causing the issue first, such as these furocoumarins and the psoralen, okay? If they have low values, I have them ingest them in order to help values be higher until we figure out what's causing it. So you can use them in two different ways. So the psoralins or furocoumarins, if something's high, get them off of it. If something's low, get them on it to help normalize it until you can figure out what's actually causing the issue, okay? Citrus bergamot is said to help lower bad cholesterol similar to statins, but it's a natural source. Is it safer than the statins? As far as I know, it probably is. And I've read somewhat on it, but one of the things that I think you need to look at is too much of anything can cause a problem. And we're going to be talking about mega doses of vitamins and minerals and things of that nature in a future course here. So we're going to be getting into that sort of thing here, okay? That's a good question. Thank you. For example, now this is somebody, yeah, you're welcome. For example, a 60-year-old plus obese woman experiencing elevated parathyroid hormone with no tumor was eating 3 grapefruits per day. Now, I had to question because there was no tumor. Okay, no tumor. That's the first thing you think when you see greatly elevated parathormone. But I noticed she was obese. I said, "Are you eating grapefruit?" She said, "Well, yeah." And I said, "How much a day?" She said, "Well, 3. I want to lose the weight, and I heard it's really good." I just merely told her to stop it. Her parathormone normalized in 3 to 4 weeks. MDs had no idea what caused it. But because I knew this stuff about the psoralins, the furocoumarins, and I rationalized that, hey, this could affect the blood value of our own innate hormones that's already inside, and it can cause problem with maybe any blood chemistry. And I just started playing around with it, folks, and it turns out you can. How many of you ever had that thought before about using psoralins to help normalize blood chemistry, either to lower anything that's high or anything that's low? Let's see that in the chat box here. Yes, Dr. Donaldson. Yes, Dr. Weeks. No, Thompson. No, Dr. Payton. And I'm here to spur your thoughts, Dr. Garbett. No, okay? This is here to get you to think more about things that you never thought about before, as should any seminar be, okay? Anything that you take. Okay, thyroid hormones. Let's go a little bit different direction. Let's be a little specific with a very specific one. Goitrins or goitrogens can cause decreased production or function of thyroid hormones. Therefore, if someone has decreased thyroid hormone production or function, we get them off these foods, substances. But if they have elevated thyroid function, we have them ingest them to slow production or function of the hormones. And I've had, I don't know how many people that had low thyroid function. We got them, we went over the foods that are high in goitrogens or goitrins, and I just said, hey, cut all these out. And they did, and I'm talking within a month or two, they were off the thyroid hormone entirely because it was due to the amount of foods. And the heck of it is, most of these are listed in the physician's desk reference that it'll do this. And the MDs don't even mention it to people. Okay. Now here's somebody that came in, and she's a 37-year-old female, was experiencing thyroid storm. She was told she needed her thyroid taken out or injections of radioactive iodine to kill it and to put her on thyroxine the rest of her life. She said, I don't want to do that. I don't want to be on thyroid hormone the rest of my life. So I just went over the list with her, and I told her, eat a lot of the goitrogen-containing foods. A month later, she came back and she was hypothyroid. So the very foods that depress thyroid function I told her to take more of them. They got her out of thyroid storm. And I've done that with regular hypothyroid and Hashimoto's thyroiditis. It works on all of them, folks. And it's really easy to do. You just give them the list, say eat more of those. Now, she came back and she went hypothyroid. So I said, well, eat a lesser amount just to keep you at a normal level, which she did. And this has been almost 20 years now. She's still a normal level. I just had to show her what foods to use and about how to use them. And it was just that simple. I didn't give her anything else. I didn't give her any other nutritional information. It's about that. So, hypothyroid foods. Now, I want you to note, milk can carry any of these because they're fed to the milk-producing animals and pass into the milk. So when you're talking about these particular things for thyroid, get the people off of milk majorly because that can cause a problem. So goitrins or goitrogens prevent the thyroid gland from producing thyroid hormones or prevent thyroid hormone from being used properly. In other words, it's there, but it just can't be used right, causing relative or true thyroid hormone deficiency if eaten regularly in large quantities in susceptible individuals. What are the foods? Brussels sprouts, cabbage, carrots, cauliflower, cassava, which is in tapioca, kale, kelp, peaches, pears, rutabagas, soybeans, canola, spinach, turnips, mustard, peanuts, pine nuts, and millet. Now, if you notice there, many of the above are eaten to lose weight. How many of you have had people come in and they start eating a whole lot of salads and they gain weight instead of lose it? Let's see in the yes box over here. How many of you have noticed that? Let's see the yes or no in the right side. How many of you have noticed that people get on a really healthy diet and they gain weight instead of lose weight like they want? Dr. Donaldson all the time. Dr. Thompson, no. Delgado, yes. No. Dr. Dixon, yes from the next. Okay. Well, that's why. And look at this. These are crucifers. And a lot of people are eating cruciferous vegetables to prevent cancer. And then it makes them gain weight because it lowers their thyroid hormone function. Okay? Oh, Dr. Johnson, recently married. Congratulations. Hope New York is treating you good. Okay, now wheat, in addition to these, can inflame the thyroid gland and result in either hypo or hyperfunction. Okay? So, in either way, if you have hyper or hypothyroid, get off of wheat because you may be a susceptible person that it's causing it to go one way or the other. Caffeine. Frequently, the action of a hormone is magnified by the addition of theophylline, including caffeine, to the system. Therefore, if you have too high hormone levels, back off on foods and drink with high caffeine levels. If you have too low hormone levels, take more until the situation is corrected. Okay, wow, added an it in there. Sorry about that. So, how many of you knew that caffeine magnifies hormone levels? Let's see that in the chat box over here. How many of you knew that caffeine magnifies hormone levels in general? Dr. Delgado, yes. Peyton, yes. Garbage, yes. Peyton, no. Thompson, no. Donaldson, yes. Nope. Dr. Weeks, Johnson, yes. Okay, so some of you knew it, some of you didn't. Caffeine is high in coffee, tea. Brewed tea is higher than coffee. Energy drinks, sodas, excepting Sprite and 7-Up primarily, and chocolate. Now, these are things that we're being told, hey, you know, eat a lot of these because they're high in antioxidants, they're really good for you, they're healthy. Then it starts playing around with your hormones. You don't know what to do. You don't know where it came from. The doctors really aren't aware of that. Okay? They'd be questioning you on that. Salt. The ingestion of a salt with a starchy meal causes an increase in the height and duration of the blood sugar curve following the meal. Salt either boosts ingestion of food in the intestine so that more sugar is released from it, or it stimulates the intestine to absorb sugar more efficiently. It's also possible that salt may have inactivated insulin or suppressed its production. So, how many of you knew that use of salt with a meal raised blood sugar? How many of you knew that? Let's see that in the chat box there. Dixon, no. Donaldson, no. Garbitz, no. Okay, so Thompson, no, no, no. So anybody who has somebody with the metabolic syndrome or with diabetes, tell them, hey, back off the salt, because that is actually causing your blood sugar to go higher. Sugar. High levels of blood fats interfere with the ability of the body to lose insulin. If one lowers them, the body's use of insulin returns to normal. Hypertriglyceridemic patients consume greater amounts of sucrose, alcohol, and total calories. Sucrose and fructose in the diet increase serum triglycerides, causing hyperinsulinemia. Eliminating them decreases it. Okay? So, how many of you knew that especially sucrose and fructose elevates serum triglycerides and therefore cause a problem with insulin sensitivity? Dr. Garbage, yes. We have several yeses on here. That's because you took my course, right? That's right. Okay. Well, I'm glad that you knew that. Garlic and onion, though a little slower in action, are as effective as tolbutamide in clearing the bloodstream of excess glucose. Hey, we have a new word here, glucose. I wonder if that's the same cousin of redcose. Okay, sorry, getting off the topic here. Excess glucose. So how many of you knew that garlic and onion could be used as to help regulate blood glucose level and is as effective as tolbutamide? How many of you knew that? Have some no's, have some yeses. Okay, that's good. Of course, you got to watch and see if they are having an adverse reaction to the volatile oils in garlic and onion too. Desiccated liver can be used as a substitute for insulin without the side effects. You know, that study was done like in the 1920s. How many of you knew that desiccated liver could be used directly as a substitute for insulin? How many of you knew that? Desiccated liver. And this is so simple. This has been known for like a century now. There was research done a long time ago about this. Provocative foods. 2/3 of insulin-dependent adult-onset diabetics don't need insulin after withdrawing from maladaptive reactive substances. Those still using insulin require only 1/3 the amount used prior. Both carbohydrate and protein foods shows sensitivities. How many of you knew that food allergies, both carbohydrate and protein, just getting people off of that could get them off of insulin or dramatically lower the insulin they're taking? How many of you knew that? Let's see that in the chat box. All the time? Yes? No? Okay, we have kind of a mixed bag there. Okay, sure, that's good. Myrtlein, found in all green plants, tends to stabilize blood sugar, otherwise fluctuating wildly, and it spares insulin. Now, myrtlein is found in all green plants. So, how many of you knew that green leafy vegetables acts to spare insulin? How many of you knew that? Green leafy vegetables act to spare insulin directly. And this is right out of the literature. See, this stuff is so simple, I'm telling you. You just got to pay attention. You got to look at the individual and just start knowing these things and asking a couple of questions. Exocrine pancreatic insufficiency associated with juvenile and maturity onset diabetes responds well to pancreatic enzymes, bicarbonate, and amino acids. Wow. So pancreatic enzymes, bicarbonate, amino acids helps juvenile onset diabetes. How many of you knew that you could help juvenile onset diabetes? Let's see it over here in the chat box. These are supposedly people that you cannot help at all. How many of you knew you could actually help juvenile onset diabetics? We're going to see another way to help them too. We have two different ways to help them that you're going to see tonight. Okay? And most everybody did not know that. Dietary fats. Low cooked fat diets improve the insulin mechanism and reduce the need for insulin medication. Cooked versus uncooked foods. Pure uncooked starch gives virtually no rise in blood glucose, but cooked gives dramatic differences between different foods, and it's unpredictable how each food will be reacted to. Foods in the glycemic index were all cooked. Okay, how many of you knew that raw food gave virtually no change in blood glucose, but it was the cooking that actually caused the problem in the glycemic index? How many of you knew that? Dr. Dixon, yes. Okay, another yes in here. Thompson, no. I think you all took my seminar, so you saw my master's essay that stated that in there. Okay, Delgado, no. That's good. We're learning something here. Raw food diets restore blood sugar to normal. Societies that eat either high carbohydrate or essentially raw meat have little problems with blood sugar. And this is from studies that have been done around the world. High carbohydrate meals have little effect when cooked fat is curtailed. And this is complex carbohydrate. So not the simple carbohydrate. Amount of food ingested. Pre-diabetics given carbohydrate in 4 equal small meals per day see no blood sugar rise. But given in 1 large meal, blood sugar raises into the danger zone. Okay? This is why I have a problem with this intermittent fasting, where you're fasting for 16 hours a day. A lot of these people are eating 1 large meal. Okay? So I tell people, yeah, go ahead and do the fast. I don't have a problem with it, but eat a meal right when you wake up, in the middle of the 8 hours, and at the end of the 8 hours. That way you got at least 4 smaller meals and not 1 large meal. Okay? So how many of you knew that eating 1 large meal in a day made you more at jeopardy of having diabetes rather than smaller meals? How many of you knew that? Okay, we have a yes in here. Yes, that's good. We have some agreement. No, didn't know that. Okay, diets high in carbohydrates improve glucose tolerance in normal persons when caloric intake is controlled. So if you overeat, that's mainly when the carbohydrates cause a problem. Carbohydrate versus protein meals. Potential diabetes can be activated, and mild diabetes can be made severe by too rigid a restriction of carbohydrate. How many of you knew that restricting carbohydrate can make you more prone to diabetes? And this is complex carbohydrate. How many of you knew that restricting carbohydrate can make you more prone to diabetes? Let's see that in the box over here. Yeah, we're taught just the opposite, right? So I want you to start thinking cook less and eat less in the way of simple sugar, simple carbohydrates, okay? High complex carbohydrate, about 75% of the diet. Low simple sugar, high fiber diet does wonders to reduce and eliminate insulin need. Now this is Dr. Anderson, and he did a large study on this, got almost all the people off of insulin. He did another study with raw food, and virtually all those people got off insulin. So this Dr. Anderson, an MD, was really good at that, and he actually, found a whole lot of stuff that worked in the way of raw food and carbohydrate. Okay, trivalent chromium. The glucose tolerance factor is the only type of chromium thought to be biologically active in the human body, and it's mainly found in brewer's yeast. Brewer's yeast has like a rating of 44. The thing next to it is black pepper. And then it goes way down from that. Black pepper is way down. It's about a fourth of brewer's yeast. It sensitizes tissues to insulin and is secreted from the liver in response to a meal. So anybody that I see that has any type of blood sugar issue, I have them immediately get brewer's yeast and take a half teaspoon twice a day. And whether they're high or low, this really helps stabilize them quickly while we're correcting all the other issues that got them there. Okay? Now somebody needs to mute themselves, and I can't see from here who you are, but you're not muted. Oh, there we go. I just found you. Okay. Vitamin C, chronic feeding of high acid producing foods such as wheat and cooked animal protein increases dehydroascorbic acid, which is the oxidized form of ascorbic acid, with the emergence of a parallel hyperglycemia and lowering of ascorbic acid. Humans, including juvenile diabetics, have been shown upon administering high amounts of vitamin C to have improved action of insulin, with lower levels of insulin being needed to control sugar metabolism. Vitamin C is necessary to convert glucose to glycogen for storage in the liver. Continued deprivation of vitamin C develops degeneration of the islets of Langerhans in the pancreas and an extremely low sugar tolerance level. Okay. Now I had a diabetic come to me, and he was 27 years old, very slight, like 5'7", probably weighed 115, 120 pounds. And he had lost all the sight in one eye from leakage of blood into the orbit, and he was starting to have leakage into the other one. He says, I don't mind taking the insulin. I've been a diabetic diagnosed since I was 3 years old. Said, but I don't want to go blind, and I heard you do things a lot different than everybody. So we changed his diet to an alkaline diet, had him take 5 grams of vitamin C a day for a while, and within 3 months he went from 40 units of insulin a day down to 17, and 27. Then another 3 months he was down to 13. He moved to Arizona, and he called me real excited about 6 months later. He says, I'm totally off insulin. First time since I was 3 years old. Now he was 28 years old. And we got the juvenile diabetic off of insulin by using these principles. Okay. How about that? It's pretty cool. Milk and sugar combined are diabetogenic. So what do we feed our children? Cereal with milk and sugar, right? And what do we have? We have ice cream, which is milk and sugar in it. Boy, we're just asking for it with that one, right? Growth hormone, prolonged administration causes osteoporosis and diabetes. It's demonstrated in milk and is not destroyed by pasteurization. So here we have not only people drinking a lot of milk, but they're taking human growth hormone to feel younger again. And they're giving themselves osteoporosis and diabetes. How about that? How many of you knew that had? Is this the bovine GH or the HGH? Both of them. Because the HGH has the same effect. Okay? So when you have anybody with any of these, osteoporosis, diabetes, get them off of milk. Okay? Get them off of sugar. They're just asking to be put into it. Alloxin and streptozotocin. Insufficient insulin production is induced in animals by these chemicals. Alloxin is created by oxidation in the bleaching of wheat flour and sugar to make them white. Wow, so all of us, when we're having white sugar or white flour we're getting alloxin, which is used to induce diabetes in animals. What it does, it causes the islets, the beta cells in the islets of Langerhans to swell and rupture and then not work anymore. Streptozotocin, that should be is an N-nitroso compound formed by smoke-curing meats. Look at how much more smoke-cured meats that we've been getting into here. In the last several decades, that's been on the rise by quite a bit. So these are things that we're doing every day that we can make a big change in to correct hormones. And why did I go into this depth? Well, I did my master's essay in it for this, but if you're prone to blood sugar issues, you're more prone to having all sorts of other hormone issues. So when you correct the blood sugar, you're automatically going to be addressing the other hormonal issues without even looking at them. Okay. Now, before we move on, does anybody have any questions about anything we covered in this main body tonight? Anybody have any questions about anything we covered in this main body tonight? Okay, we're going to go to next topic here. And now we're told about evidence-based medicine and that we ought to be practicing it, but nobody tells us what it is. So basically, I took it off the ACA website, okay? And they got it off of somebody else's website, as we'll see. So we hear about evidence-based medicine and best practices. So there's the American Chiropractic Association, right in here. And oops, did I go past it? Oh, there we go. British Medical Journal, right here. Basically, what we're looking at here is the evidence in research and what you experience in practice. In a nutshell, that's what they both are. And you are welcome to a copy of this. As you see in your Zoom application there, you can click a button and request this, and I'll just turn around and send it to you, or you can send it to my email. And that's fine too. I think everybody ought to have a copy of this so that they actually know what they're talking about when they talk about evidence-based medicine and best practices, because most of us assume we know what it is, but we really don't. Let's see here. Okay. Now I have videos available. And guess what? Part 4 is started to come out. I've been promising that for a while. And Part 4A is out. Went out about a week ago. And I'm hoping the rest of it will be out after this weekend. So you can get that. We're going to go over this a little bit. Now, basically, pre-production, these are $250 each for a year's viewing. Post-production, it's $500. But since you didn't know about it, I will, if you order it right away, I will give it to you for that. Okay, Dr. Weeks, you have to send me the request in my email. I can't record this here, so I'm going to put my email up here, drBBRK@hotmail.com. Right there. You have to email me for that, Dr. Weeks, okay? Okay, post-publication price when COVID-19 is over. Well, that may be 5 years from now. Okay, we're going to go over these a little bit. You can also go online, ttapcenter.com, seminars professional. Go to the seminar that you want, 1, 2, 3, or 4. Under requested location, type in film and your phone number, and click the down arrow and choose 250. So you can order it online like that. Okay. And what are they about? T-TAPS Part 1. This is basically about reflexes alone, myotatic reflexes, which is stretch reflex, and some minor scar tissue in the skin. Using those, you can get fantastic results you never heard about before. You can normally get someone off a cane or a walker in 1 or 2 visits, or standing up out of a wheelchair in just a few visits, if it's due to weakness instead of paralysis. Immediately restore a significant range of motion. You understand how reciprocal innervation can immediately help restore function in distant parts of the body. Correct foot drop in the majority of cases in a visit or 2. Cogwheel rigidity of an arm and leg, stroke and cerebral palsy patients. Improve hearing and tinnitus in most cases. Fulfills the ACA evidence-based practices. And these results are very, very quick. Fibromyalgia pain, sciatica. Now, basically, you do your standard orthopedic neurologic tests. They're all verifiable by those. It's not something that you hope for. It's something that you see immediately with that. Sciatica with Lasag's, herniated or bulging disc, Milgram's, unoperated rotator cuff, frozen shoulder syndrome, regional pain syndrome, formerly RSD, cranial nerve symptoms like nystagmus, strabismus, check with Weber's, hearing loss, different frequencies, tinnitus, foot drop, all the tunnel syndromes, cold or burning hands or feet, Raynaud syndrome, loss of vibration sense in the feet and toes, dizziness, vertigo, positive pinwheel test, bladder leakage, MS symptoms, Parkinson's. Just had a guy, he's a diabetic, came to me today. He's had 20 years, hadn't had sensation from the midfoot forward on the bottom of his foot. We restored it took about 5 minutes. I don't think it took that long. Probably took about 2 minutes. Just did that on a guy today. He's 29 years old. Burning tongues and mouth syndrome. Burning pains of lower extremities or genitals and upper body. Female cyclical menstrual pain. Vaginal prolapse, numb hands and feet. Drop transverse cuboid, longitudinal arches, hyper and polyhydrosis, cogwheel rigidity, ALS symptoms, Guillain-Barré symptoms, seizures, and a lot more than that. Don't miss that. Now, that deals again with reflexes alone and some minor scar tissue in the skin. Now, this is not reflexology, AK, CRT, PNT, TBM, transverse friction massage, spinal reflex therapy, or contact reflex analysis. It's based on known tenets of acupuncture, trigger point therapy, reflexes, and neurology found in the laws and tenets in Dorland's Medical Dictionary. I read this stuff straight out of Dorland's to you, for example. Chusage Neurophysiology, Guyton's Medical Physiology, all taught in CCE accredited colleges. They're verified by standard orthopedic neurologic exam. I am published in JMPT, Chiropractic Economics, on the techniques being taught. And I'm a former adjunct faculty member, postgraduate division, Texas Chiropractic College. So I got, some pretty fair credentials here. Now, that leaves part 2. Now, the first part of part 2 is a continuation of part 1 because we didn't have enough time to get to it. First thing we do in part 2 is to show you how to easily test over 200 muscles in the body in less than 10 minutes. And I don't care whether you have 3 or 53 weak muscles in your body. We have you lightly touch one muscle based on the test that you did. And instantly you retest the muscles and they're all strong. That keeps you from having to go from muscle to muscle as in applied kinesiology. Now, I've taught 7 diplomates of applied kinesiology. They can't believe I came up with this stuff. They're just like, wow. And it's stupendous. The only exception to this is if you got a severe amount of atrophy, it's going to take a little longer for the muscles to come along. Second thing we teach is to palpate the whole body, no matter how many areas there are pain to palpation. And it takes about 5 minutes to do the palpation. Lightly touch one spot like this and boom. Wow. Can't snap real well there. Okay. instantly you go back and you repalpate. It's not painful, the palpation. The only exception being if you have severe inflammation, even that pain will drop in half immediately, but it'll take a little longer to settle down. This keeps you from having to go from trigger point to trigger point, as in NIMO trigger point therapy and manual trigger point therapy like that. So it's very, very quick. Second thing we teach is to how to rehab somebody in about a fourth of the time as normal, which is very eye-opening. And the third thing, we show you how to take dense scar tissue outside the joint and just in a couple of seconds basically free it up. And now this contrasts with ART, which in their seminar says it's going to take 4 to 6 visits to clear out a muscle. In Graston, with their expensive instruments, they state 6 to 10. Transverse friction massage, right in Celiac's manual, says 10 to 20 visits. And they all are very painful, take a lot of time on a visit. They wear you out. It's very painful and leaves bruises on the patient. We show you how to do it with the minimum amount of effort in seconds and a lot less pain to that patient. And so you get a lot more done in a lot shorter period of time. Really stimulates referrals, okay? Now, what are some of the things that you take care of? Chronic athletic injuries, for example. And this applies to the average person too. Hamstrings, ankles, wrists, golfer's elbow, tennis elbow, rotator cuff, knee, turf toe, shin splints, chondromalacia patella, weak ankles, trick knees, etc. Plantar fasciitis, myalgia, paresthetica, bronchitis and asthma, gagging, esophageal spasm, reflux esophagitis, TMJ syndrome, migraine headaches, chronic whiplash, chronic hip, knee, ankle, shoulder, elbow, wrist pain, tendonitis and bursitis, adhesive capsulitis, frozen shoulder, Dupuytren's contracture and trigger finger, Osgood-Schlatters disease, chronic fever and sore throat, scar tissue and acupuncture, old fractures, chronic pain, bone sclerotome pain, fibromyalgia, burning pain, resistant sciatica, spondylolisthesis, necessity using cane or walker to walk, herniated or bulging disc, rotator cuff, frozen shoulder, foot drop, hearing loss of differing frequencies, tinnitus, carpal radial thoracic tunnel syndrome, etc., all the tunnel syndromes. Small joint fibrous ankylosis, chronic shingles pain, arthritic finger and toe joints, unadhere organs from each other and stimulate circulation and lymphatic flow, diaphragmatic and accessory breathing muscle function, endonasal technique, we show you like 4 different ways to address that, and eustachian tube techniques. For chronic sinusitis, migraines, eustachian tube deafness, Meniere's syndrome, female cyclical menstrual pain, vaginal prolapse, dizziness, vertigo, unexplained chest pain, MS, Parkinson's, ALS, Guillain-Barré symptoms, ankylosing spondylitis symptoms, seizures, and a lot more. And again, it's all backed up by standard tests. Now, that addresses a dense scar tissue outside the joints. That leaves dense scar tissue inside the joints, which is TTAPS Film 3, adjusting, manipulation, mobilization of extremities, cranials, and vertebrae. Now, my background is I've seen over 40,000 patients from all 50 states and 97 countries, over 3,000 of which were high-end university, collegiate, and professional athletes. Over 800 of them were professional. 12 professional athletic teams, and I was the first chiropractor asked to treat the NFL Run for Daylight and Fast Man competition. By the way, 3 of the professional athletic teams were foreign national teams. So here's some joint issues: rib and costal cartilages, golfer's and tennis elbow, chondromalacia patella, bunions, dementias. By the way, we show you how to immediately cause a flushing of blood into the face and get people talking and come out of their dementia very quickly. I'm talking about it, most of them in minutes, by treating the knee. That sounds fantastic, but I've done it on several people at the seminars. High arches, flat feet, dropped arches, reliably relieve reflux esophagitis, esophageal spasm, upper GI conditions, hiatal hernia. Yeah, we teach an osseous adjustment that actually is the cause of the hiatal hernia. And we're not showing you how to adjust the stomach down like they do in applied kinesiology. It's very, very effective, and we explain the mechanism for it. Acromial and sternoclavicular joints, chondritis, costochondritis, hallux rigidus, hammer and claw toes, bow legs, knock knees, frozen shoulder, adhesive capsulitis, rotator cuff, all the tunnel syndromes. Now the cranial techniques, I've gotten autistic children that were speaking in squeaks or just single words to start speaking words and then sentences, then significant demeanor changes. They speak paragraphs, then they go back into class with normal children again. Eosinophilic esophagitis, yeah. Yes, that too, Dr. Weeks, yes. And a couple of docs, one of them said, I didn't believe you. I went back home. I had this patient, 5 years old. Parents brought him in. He'd never spoken a word, 5 years old. He called me up. He didn't just write it to me. He called me up and he says, I did your 3-minute procedure, which is very light touch. And the child turned around and said, thank you, doctor. First 3 words he ever spoke. And the parents started crying. He started crying. He couldn't believe it. And another doc said the same thing. Child hadn't spoken anything. He started speaking after he adjusted him in the way that we teach the cranials. I'm the only chiropractor on the recommended doctors list in the state of Texas. It's because it works like that. Stop elusive migraines, improve vision, hearing tinnitus, improve elusive organ and gland dysfunctions, TMJ dysfunctions, all that sort of thing. Okay? Now, all those, the first 3 address the nervous system. Okay? And what you're going to see is when you apply the first 3, because the nervous system controls the secretory and excretory events of the body, you free up that nervous system. A lot of resistant biochemical issues that you've been trying intervention on unsuccessfully just clear up by themselves because it was actually a neurologic issue. Okay? You're going to find that when you do parts 1, 2, and 3, you have to do far less nutritional intervention because you're going to know far more about how to correct the nervous system function. Now that leaves part 4, which is biochemical individuality strategies. And again, we just put out part A of that, and I'm hoping to have the rest of it out hopefully through this weekend. Now, I hold an MS in biology emphasizing human nutrition. That's an in-class type of deal. It's not on the internet. I'm a master herbologist. I've been a member of 6 nutritional medical and scientific boards of major nutrition companies. I've performed over 15,000 nutritional assessments. So we show, for example, strategies to significantly accelerate correction of allergic to virtually every food. They can't eat anything. Autoimmune disorders that really aren't. We explain to you the biochemical mechanism of autoimmune. Most people totally misunderstand that. Dysmenorrhea, excess and prolonged flow, bone mineralization, osteopenia, osteoporosis, and fracture, infection, natural antibiotics, endogenous poisons, metabolic intermediates, hormone imbalances, seizures, ulcers, bleeding ulcers, constant bloody noses, fungal, candida infections, chronic fatigue. Now, I want to emphasize here that we take you from the very start because we show you nutrients, for example, and we show you what foods have them in abundance. And I ask you after every one, does it seem reasonable that anybody, unless they're eating purely junk food, is low in this, putting it in their mouth? And every doctor's hand goes up. No, it doesn't seem reasonable that they're not putting it in. So therefore, it has to be a problem with digestion, absorption, transport through the blood, transport through the cell wall, transport through the mitochondrial membrane or the nuclear membrane. And then it has to be broken down to its minimal biochemical status and then secreted or excreted. If you don't have all of those steps, then you're going to cause a problem. Then we show you about the negative feedback loop. For example, when somebody is having a problem with electrolytes, what do we normally do? We say, okay, give them electrolytes. Yeah, that's what we're taught. We're taught to basically give them something for the symptom. But what controls electrolytes? Androgens. What controls androgens? Progesterone, which also controls, by the way, cortisone, which controls swelling and inflammation. What controls progesterone? Pregnenolone. What controls pregnenolone? Vitamin D3 and, through a negative feedback loop, estrogens. Now, pregnenolone controls progesterone, but also DHEA, dihydroepiandrosterone. And both of those control testosterone, and that controls estrogen. So we show you how to take somebody with lower zero T, for example, and get them back to totally normal T in maybe 3 or 4 weeks, just by manipulation of food and affecting those particular areas. Okay, quite eye-opening. Why supplementation for deficiency seldom corrects it? We get into a lot of different things for that. Obesity, all the things involved with that, abnormal cell growth, nutritional cause and correction, for example, of behavioral disorders, hyper and hypotension, bone demineralization, depression, hyper and hypothyroidism, hyper and hypoglycemia, failure to digest, absorb, metabolize, secrete, excrete, acid-base imbalances, and that's not what you think. A lot of people have wrong ideas about acid-base. And I would urge you, if you haven't taken the courses, get these and get the films and go over and over and over them. Now, one of the things about these films, I urge you to watch them start to finish, but we also make them very user-friendly because we have timestamps on them. So if you want to go to something specific, you hit the timestamp and it drops down on the bottom. You go to the category you want, click on it, takes you right to it, so you don't have to go search for it. Very, very user-friendly. And I would suggest that either call me up or you go online and get that. And I would suggest that you do that. Again, you do it in the next couple of days. I'll give them to you for pre-publication at $250. It's going to go up later on if you don't. Okay. Now let's go back to another one. Okay, now I do mentoring, and I've taken 32 different practice management or consulting courses or practice coaching, and all of them had, some things that I thought were lacking, and they had some good things. I learned some stuff. Interestingly enough, my practice was always at the very least 3 to 5 times bigger than the guy giving seminars from the very start when I started going. You learn something in everywhere you go, right? Here's some testimonials. Dr. Bonebreak's Preeminence Mentoring Program is what I've been searching for my entire career. It's Dr. Larson from Minnesota. Dr. B's mentoring program is second to none. Wealth of knowledge and expertise. This guy is from California. Dr. Bonebreak's mentorship program, the best investment I've ever made. I thought I was a good doctor before meeting Dr. Bonebreak, etc., and he was. This guy's from Cleveland. Since mentorship with Dr. Bonebreak, I've seen several improvements in my practice. I see patients getting their desired results very quickly, etc., etc. This doctor was in Chicago. He reached his ultimate practice. He decided, I'm going to go down to Florida. So he's down there, and we're helping him start from zero again. He just started off with a bang. I wasn't sure if I needed a mentor, as I already thought my business was very successful. And he attended with his brother, and he saw way good improvements very quickly. He's from Houston. He's in the mentorship. I can't believe how much my practice has changed and grown since I began mentoring with Dr. Bonebreak. Mostly sports chiropractic. This guy's in Fort Worth, Texas. He's gotten excellent results with it. I've been in private practice 23 years, owned and operated a successful sports chiropractic clinic in Austin, Texas. And he really loved it. No fluff, no cookie cutter, no one size fits all. And he is in Austin. And, I'm not trying to make you into my practice. Now, I averaged 640 new patient calls every single month. You heard that right, not per year, per month. And at 911, when most practices went down in flames, 30 to 50%, some of them 75%, mine went up 1,700% and stayed there, okay? This is what I want to teach you. I am nothing more or less than a shortcut for you to learn how to practice more efficiently, both with the techniques to get people well and to streamline your practice to make you as successful as you want to be. And I never try to guess at what you want. I say, okay, where do you want to go? And let's show you how to get there, okay? Very, very quick, just like that. I'm Gilbert Danforth, Doctor of Chiropractic, and he takes into consideration your personality, your fears, your desire to be successful in the areas you want to. He's in Lubbock, Texas. Having been a sole practitioner 25 years, I've been in my fair share in seminars and plethora of salts and techniques. And frankly, I thought I'd seen about it all. I was wrong. I first attended T-TAP seminar, Dr. Bonebreak. This guy's in a suburb of Houston. They're all getting great results. And basically, we're going to show you how you can, join and get that too if you so desire. So here we are in preeminence mentoring, is which I dubbed it. And basically, what I want is, why I'm doing all of this stuff is to get chiropractic to the masses, get everybody their dream practice, and get people the health care that they deserve. Okay. Preeminence mentoring is a good fit for everybody. It enables you to become top level, rapid, efficient patient response with scientific methodology found in medical literature, become a nerve biochemistry expert, gets referrals from everywhere. I've seen people from all 50 states and 97 countries, over 44,000. Get paid what you're worth, low stress, better family time, others committed. Now it's your turn. I got one of the doctors. He's practicing. He's a young doctor. He's only practicing 12 hours a week and has a superb income. And I said, what do you want? He said, it's that. I said, okay, let's do it for you. Imagine having, just close your eyes. Imagine having the business of your dreams, smooth running, plenty of highly satisfied and enthusiastic patients, as many as you want, financial security, time to enjoy with your family, time to exercise regularly, and great health. 3 reasons it works for you. You will develop the effort, time, and dedication to get what you want. Charisma certainly isn't necessary. I talk monotone. My wife wonders why people don't fall asleep in the seminars that I give. And I'm certainly not a David Singer, man. He has charisma going out from every orifice that he has. I certainly don't have that. I misspell things, even on the things that I'm giving right here. You don't need that to have an excellent practice. You just don't. Group or one-on-one mentoring is very affordable. And your next step is to commit to be superlative. Go to the link, ttapcenter.com, choose the mentoring level that fits you, or you can call me, and I'll give you my phone number again. Commit to change your life. Mentoring includes, and other mentors in practice management don't do these things. Okay, 12-month group mentoring. So it's one group call per week for 12 months. So that's 52 of them. It's $500 a month, or one payment of $500, or $5,000, which saves $1,000. You receive 52 one-hour weekly real-time group interactive podcasts. Anything you want to know in practice, you hear all the other doctors asking their questions. You ask yours. You learn from the questions, from the answers I give them. And step up your practice to the level you want and desire. Up your income dramatically in accordance with your level of commitment. How to get paid for what you do. Run your practice in the most efficient manner possible. think and reason quickly in any practice situation, give talks that get lots of new patients. I gave weekly talks for a long time, and I averaged 35 to 50 every time without advertising, and almost all of them every week became new patients. Okay? Don't ask patients for referrals. Get scads of them. Communicate in a way to draw referrals to you from all over. Show you how to testify in court and depositions. Write narrative reports in the best manner possible to help the attorney to get a better settlement. Situations or answers to solve your situations. How to best treat given conditions for quick results. You know, most of the practitioners that call up know that getting the best results on the patients is going to be the biggest thing in the practice. And most of the calls that I get are, what I do with this patient, I'm having trouble with them. I say, okay, part 1 you do this, part 2 you do this, 3 this, 4 this. You can choose to step up to the 1-year one-on-one mentorship in the first 3 months and get those benefits as well. Next one is 6-month one-on-one mentoring. 1 call a week for 6 months. That's $26,000 a month, or one payment of $4,000 saves $2,000. To receive one-on-one mentoring from me, any aspect of your practice, just you and me one-on-one. We're going to cover what's at the top of your radar first. Again, I'm not here to make you a mini-me practice. You know what's wrong with your practice. I say, okay, I want you to keep a notebook with you all week. As you think of things, you write down things that you want to ask during our session so we don't miss it, okay? And we cover what's right at the top of your list. And it can be as much as starting from the very first time that a patient calls to the very first time that you see them. To getting them to follow through care and all that. If you decide to step up to the 1-year one-on-one mentorship in the first 3 months, you get all of its benefits. Now, the 12-month one-on-one mentoring, 1 call a week for 52 weeks, is $1,000 a month, or one payment $8,000, which saves you $4,000. It includes all 4 of the films for a year, plus a link on your website. See, when I'm done with the films, I'm going to, I have thousands and thousands of doctor and patient testimonials where we're going to put them on a link that you can go through on your website, and patients and prospective patients can look at it, go to their condition, see doctors that are using T-TAPs and patients that received it saying, wow, here are the great results. And that convinces the patient even more than you saying you can do it, because they're seeing people that actually had it and doctors that are using it on patients. And we're going to have this for each section, 1, 2, 3, and 4. And I'm creating part 5 for acupuncture and acupressure, which I already gave in Texas once, but we're going to do a 5th film too. At any rate, I put these up on my website, and it was good for 20 absolutely new patients for each section, 1, 2, 3, and 4. I sent a notice out email to all my patients, and I said, go on there and look. And they looked and they said, I didn't know you could take care of this stuff. I have some other stuff I need you to take care of. So they came in 20 per month, every month. So it was good for me for 160 essentially new patients every month. Now, even if you don't get the 1-year one-on-one, you can get this for $50 per section to help you build your practice, which is well worth it, okay? So it's $50 per month. Doctors' blogs, $50 per month for each course. You get to interact with the other doctors. They're going to say, hey, I used this on this patient, this results I got. I'm having trouble with this. What would you do? And another doctor says, well, I've had success doing this and T-TAPs plus this. So you're going to learn more than T-TAPs, because you're going to have the cumulative experience and expertise of every doctor. If y'all get stuck on there, you say, Dr. Bonebreak, we can't figure this out. What would you do? And I go in and I put my 2 cents in and say, well, I do this from part 1, this from part 2, this from part 3, this from part 4. I take you right to it, and I say, okay, this is what you do, and this is why you do it. Okay? So you get this, the doctor's blog for each section. It's, it's for a full year. It's included in the membership. any area of your practice, how to treat any patient issue, how to communicate. Now, just to give you an example, my mall shows, I averaged 250 new patients off of every mall show that I did without advertising. Okay? I don't know anybody that's gotten that high, especially on an average, but that's what I did. Access to notes from each of the 4 TTAP seminars, all 4 videos for a year's viewing, up to 12 seminars. And we plan on putting this online, hopefully for CEs in every state. And once they're on there, you can either have an in-person or an online CE. 12 of them goes right with that 1-year membership. We cover what's at the top of your radar first, what you need to know. You'll get a certificate when you master those parts. And if you decide to extend another year, it'll be just half the price. So it can be $1,000 a month for 6 months or only $4,000 for the year. Virtually everybody who's taken the first year goes on to the second year because they've had such great results. Got one doctor, he already had a multi-million-dollar practice. I improved his profitability 87% in his first year, 67% in his second year. Now he's on his third year, and he's already improved 27% without even going past what we've gone through. Commit now to achieve your dream practice. Business results depend on your effort and following directions. So basically, you got to lose your excuses. Take consistent action to improve. I am a lumbering fool. I'm very slow on the uptake, but if I want something, I just go for it. Okay? I just go for it. I make a lot of mistakes, and I figured out how to do it. Okay? I am here to help you keep from making those mistakes and cut right through it to get there quicker than I did. If you'll do this, sign up. If not, don't. I give you information and encouragement. You take action to improve your life. That's the up and down of it. So, if you want to contact me about that, I would urge you to do so. Okay, we have a thank you from Dr. Weeks, all that you teach and share. Thank you so much. Now, if any of you have any questions whatsoever, I would encourage you to ask right now. We can stay on for several minutes as long as you want to. I'm going to put my email here again, drbbrk@hotmail.com, and my phone number, 469-995-9907. Oops, didn't get that one right. Okay, so if you want to contact me, there's the email. If you want the notes from the course, or you can just click it on the Zoom there, and I'll send any of those notes to you. Call me, if you want to talk about anything. I'm here to help you. If you have a problem with the patient, call me. You don't have to necessarily be in a mentorship. I am here to help you help patients. That is my big motivation. So feel free to call me, and I will be happy to help you. Okay. I have a chronic medial epicondylitis on my left side. I've been able to get rid of it. Any ideas? This is one point in time when now. Okay, have you taken part 2? My first question is, have you taken part 2? Please put that in the chat box. Have you taken TTAPS part 2? Okay. If you recall, medial and lateral epicondylitis are the few times that I tell you to go directly on the tendon involved. Okay. If that doesn't work, you go to the opposite side and you start tapping around on that with small tip probe. If that doesn't work, you go to the knee on the corresponding side. If that doesn't work, you go to the jaw at the angle of the jaw. Okay. On the inside or the outside of the jaw. In this case, it would be on the inside of the angle of the jaw. And that's in part 1. Did you take part 1? Relative to the jaw and all the things that go with it. Did you take part 1? Yes. Okay. Then you would see that toward the end of the notes in there. If you want me to walk you through it, just call me and I'll be happy to do that. Okay. Are there any other questions right now? Any other questions? And we'll stay on for another 30 seconds. And if nobody has questions, we will cut out of here. Any other questions whatsoever, doesn't matter, any part of your practice you're having trouble with, anything with any patient, that's what I'm here for. Okay, I want to thank you for being here tonight, and in a week or two we're going to have another class on Thursday, so look for it. Thank you very much for your thanking me. I appreciate it. Y'all have a good evening, a good week, a good couple of weeks. Thank you also, Joy. Bye-bye.